Hello everyone. It is a pleasure to present to you the imaging for the cardiac surgeon lecture, although it is a virtual presentation this year. The recording will be in 3 parts, and I have no relevant disclosure for this presentation except that I am a cardiologist and I read echocardiograms and CMR exams. I am not a radiologist and I do not read CT scans. So the objectives of these lectures are to review imaging examples of congenital heart disease, of aortic disease, and of ischemic heart disease, to review typical clinical situation associated with these imaging examples, and to review normal and abnormal cardiac and aortic anatomy as it appears on transthoracic echocardiography, transesophageal echocardiography, or cardiac MR, and cardiac CT. So I will start by brief comments about when to choose what test. Then I will talk to you about ischemic heart disease with a focus on viability imaging. After that, the second lecture will be the longest one, and we will review examples of congenital heart disease. And finally, I will show you in the third lecture examples of aorta imaging, focusing on acute aortic syndrome, since the imaging for transcatheter aortic valve replacement will be covered in a specific lecture. As you already know, not every test is equally effective in all clinical circumstances and for all clinical questions. So when you are choosing a test, it is first best to choose the test that will display what you need to see in the most efficient and complete way. For example, we know by now that CT angiograms are probably the best way to measure the aortic annulus prior to a transcatheter aortic valve replacement. You also need to weigh the risk, which include radiation exposure, the need for sedation, the need to use a contrast agent. You need to know what's available and what works well in your specific institution. And finally, you have to give consideration to the cost of the tests. Cardiac imaging modalities can be classified according to their ability to display anatomy, which echo, CT, and CMR are quite good at. Their ability to measure hemodynamics, for which in terms of non-invasive testing, echocardiography is probably the best test, followed by CMR. And then by their ability to do tissue characterization and to study metabolism, which is really the strength of nuclear imaging studies. So let's start with imaging for ischemic heart disease, and I will start with a question: which of the following imaging findings indicate viability of a myocardial segment? So A, subendocardial late gadolinium enhancement of 25% of the segment. B, transmural late gadolinium enhancement on CMR. C, on a PET scan, reduced wall motion, reduced perfusion, and no uptake of FDG. D, on dobutamine stress echo, reduced wall motion at rest, improved contractility at low dose dobutamine, and reduced contractility at high dose dobutamine, the so-called biphasic response. E, on SPECT imaging, a reduced uptake of thallium-201. F, a combination of A and D, and G, all of the above. You already know that not all lesions that are visually estimated to cause stenosis truly result in hemodynamic significance. Traditionally, a stenosis of more than 70% of a coronary artery will be considered significant. It's 50% for the left main, and the vessel lumen area, as measured by optical coherence tomography or intravascular ultrasound, can help you measure the lesion size relative to the vessel diameter more precisely. However, we give a fair amount of attention to the physiological significance, which is termed ischemia, on a non-invasive imaging test. This can also be measured as a FFR less than 0.8. So what is FFR? FFR stands for fractional flow reserve, and another measurement is called IFR, which is instantaneous wave-free pressure ratio. So these are invasive measurements of pressure and flow across a coronary stenosis. So FFR is the ratio of the pressure distal to the stenosis over the aortic pressure at hyperemia, which is obtained with adenosine. If it's less than 0.8, then it's associated with provocable ischemia. IFR is the ratio of the pressure distal to the stenosis to the aortic pressure, 75% into diastole, which corresponds to about 5 milliseconds before the R wave. If it's less than 0.86, it has a strong correlation with the FFR less than 0.8, and it's normal above 0.93. Between 0.86 and 0.93, it's a gray zone. FFR has been shown superior to IVUS minimal lumen area for decision making because a minimal lumen area of less than 4 millimeters square poorly correlates with the FFR less than 0.8. On the other hand, FFR correlates well with stress CMR, but CMR results usually lead to less PCI. When choosing between invasive coronary angiography and non-invasive coronary angiography or CT angiogram, you have to consider the patient's condition, the likelihood of finding coronary artery disease, the particular clinical situation, especially the level of urgency, and also if other clinical questions need to be answered. For example, coronary CT is very good to study an anomalous coronary course. When you choose between non-invasive testing for coronary artery disease, you need to factor in radiation exposure, patient-dependent limiting factor, whether you want an exercise test or a pharmacologic stress test, and also if there are other questions that need to be answered, for example, cavity size or ventricular function. The Ischemia trial was a landmark trial in non-invasive imaging of ischemic heart disease. The premise of the trial was whether the presence of ischemia will stratify patients that will benefit more from an invasive strategy compared to a conservative strategy. So the trial recruited stable patients with moderate or severe ischemia. There was a blinded CTA to rule out left main disease, and if the patient was deemed eligible, then the patient was randomized to either an invasive strategy of optimal medical therapy plus catheterization plus optimal revascularization, or a conservative strategy focusing on optimal medical therapy alone, with cath reserved only for medical therapy failure. I'm sure that you know by now that there was no substantial difference between the two treatment strategies. The invasive strategy was resulted in a little excess of events at the beginning following the revascularization and a small decrease in events in the longer term. None of these differences were ultimately clinically and statistically significant. We will start with the first case of a 65-year-old woman with new onset heart failure and diabetes. She undergoes a stress CMR imaging study, so revealing that the LVEF is 25%. You can see here on the stress perfusion imaging that there is a large perfusion defect extending from the anterior wall, taking all the septum with even some extension into the inferior wall, and there is a perfusion deficit involving almost all the apex. At rest, the perfusion deficit is completely reversible, indicating severe ischemia in the left anterior descending artery territory. On late gadolinium enhancement imaging, there is a transmural inferior wall myocardial infarction, indicating low viability of this segment with good viability of all other myocardial segments, especially the left main territory. So the patient undergoes the following coronary angiogram, and based on these on the angiogram, she underwent a lima to the LAD and saphenous grafts to the posterolateral, the second obtuse marginal, and the first diagonal. And at 1 year follow-up, we were surprised to see that the LVEF remained 25% and the patient underwent implantation of a primary prevention ICD. So how come did the left ventricular function not improve with all this viability? So let's talk a little bit about how CMR images myocardial infarction. What CMR looks for is replacement fibrosis, and this is what you see on this late gadolinium enhancement image of an anteroseptal myocardial infarction. You see that the infarction is white while the normal myocardium is black. How this imaging sequence works is that gadolinium is an extracellular contrast agent. So if you have a scar with replacement fibrosis and an expanded extracellular space, gadolinium will rush into this extracellular space and remain trapped there. It will not go inside the cardiomyocytes. So normal myocardium will have a low uptake of gadolinium, and scar will have a high uptake of gadolinium. In this landmark study published in the New England Journal of Medicine in 2000, in patients with regional dysfunction, the transmural extent of late gadolinium enhancement is associated with the probability of recovery of function after revascularization. So if the transmural extent of late gadolinium enhancement is less than 25%, there is a good probability of recovery of function, while if late gadolinium enhancement exceeds 50%, there is a low probability that this segment will recover function after revascularization. This meta-analysis demonstrates a strong association between myocardial viability on non-invasive testing and improved survival after revascularization in patients with chronic coronary artery disease and left ventricular dysfunction. The absence of viability was associated with no significant difference in outcome, irrespective of treatment strategy. So this meta-analysis, which is almost 20 years old now, really launched the field of viability imaging. Then there was the STITCH trial, and the STITCH trial produced a very surprising result showing improved survival in patients without viability who underwent CABG. But as we will see, the STITCH viability substudy has many limitations. Therefore, the STITCH trial should be considered inconclusive with regards to the use of myocardial viability. So let's look at a few key concepts about the assessment of myocardial viability. So when there is myocardial ischemia, it results in myocytes death, stunning, or hibernation. All of that will appear as a regional wall motion abnormality. So in stunning, there is prolonged myocardial dysfunction as a result of transient repetitive ischemic insults. For example, if a vessel is briefly occluded, the myocardium is stunned, and then the coronary vessel is spontaneously reperfused. So there is normal perfusion, but the dysfunction will remain for a certain time. In hibernation is an adaptative decrease in myocardial metabolic needs in response to chronic ischemia. So, for example, if you have a wall motion abnormality with reduced perfusion, but you can demonstrate normal metabolism, then this myocardium is hibernating and it is viable. However, if there is no metabolism, then this myocardium would be scarred and not viable. I mentioned to you that that there were major problems with the stitch viability sub-study. So if you're ever asked to discuss that study, these are the things you need to remember. It was a non-randomized prospective study, and a very small proportion of eligible patients in the main stitch trial were actually randomized in the sub-study. The viability testing was optional, and there were significant differences between patients with and without viability testing. The decisions for revascularizations were not guided by the viability status. There was a trend toward higher revascularization rates in patients with viability, in keeping with prior knowledge. They used two separate imaging modalities with different sensitivity and specificity for the assessment of viability. So the imaging modalities that were used were dobutamine stress echo and SPECT, which are not the best tests to study myocardial viability. There was no use of FDG PET or LGE CMR. Stress-induced ischemia was not consistently assessed, and the group with non-viable myocardium was small. You also need to remember that there was a 17% crossover from optimal medical therapy to the CABG group. You also need to keep in mind that ischemic myocardium is viable myocardium. Therefore, you also have some information about viability in the ischemia trial, showing that the presence or absence of ischemia does not impact let me rephrase that the presence of ischemia is not driving a benefit for an invasive revascularization. Viability testing can be evaluated using SPECT imaging. So, for example, in the past, the tracer that was used commonly was thallium-201. Thallium is actively transported into the cell with the NAK ATPase. Therefore, myocytes could be considered viable if there was uptake of thallium-201. The problem is that most nuclear labs no longer use thallium-201. Most of them use tetrophosphate. So this is somewhat an outdated way of evaluating myocardial viability. PET scans are becoming more and more available, and they can test for two things. They can study regional perfusion mostly with 82 rubidium, and they can test for metabolic activity using FDG. The presence of metabolic activity indicates viability, and it also has the advantage of superior image quality compared to SPECT. I have already explained to you how late gadolinium enhancement CMR works. So just as a reminder, gadolinium is retained in areas with increased cellular volume. Therefore, the more gadolinium retained in the myocardium, the larger the scar, the lower the viability. Dobutamine stress echo relies only on contractility. So the normal response to dobutamine is normal contractility at rest with a small increase in contractility with low dose dobutamine and a higher increase in contractility at high dose dobutamine. If you have ischemia, there will be reduced contractility, even going to akinesis at high dose dobutamine. If the myocardium is hibernating, you may recruit some contractility at low dose dobutamine, which will disappear at high dose, so the so-called biphasic response. A subendocardial scar will show an increase in contractility, but it will be less than the normal myocardium, and a transmural scar will show no increase in contractility. I will leave you with these words of wisdom from panels of experts about viability imaging over the years, because there is still no consensus about using or not using viability imaging in the setting of deciding for indications for revascularization. Usually, we tend to use viability imaging in higher risk patients with the reasoning that they would be excluded from a revascularization procedure if there is no viability. But following the Stitch trial in 2014, this editorial in the Canadian Journal of Cardiology summarized the evidence by saying that the totality of evidence would thus suggest that patients with heart failure with reduced ejection fraction should be evaluated for the possibility of coronary revascularization if they are candidates for CABG. In nuclear medicine recommendations, viability imaging usually gets a class 2 recommendation, either 2A or 2B, so no decisive recommendations there as well. This is another example of imaging in patients with ischemic heart disease. So this woman is a 72-year-old female survivor of cardiogenic shock and referred to CMR for an abnormal echo. This is a short axis view of the CMR showing a large aneurysm of the lateral wall that has ruptured into a pseudoaneurysm. The LVEF on the first study, including the aneurysm, was 25%. If one would try with contouring to exclude the aneurysm, the LVEF would be about 34%. The patient underwent aneurysm resection and bypass surgery, and her post-op echocardiogram showed an LVEF of 40% with moderate MR, which is often a consequence of LV remodeling. This study is interesting because you see the differences between the aneurysm and the pseudoaneurysm. You see that the aneurysm has a rim of fibrosis around it, while the pseudoaneurysm does not. And this zoomed view shows you that aneurysms usually have a large neck, but pseudoaneurysm, which is really another word for a contained rupture, has a narrow neck. Let's move on to a third case. So a 70-year-old woman in the CCU with shock and a loud murmur. This is an echocardiogram in short axis view. You see that there is some kind of echolucency and someone measured the defect in the septum. With color Doppler, you see high velocity flow through the septum. This is an example of a post-infarct, therefore a muscular ventricular septal defect. It will produce a loud murmur that can mimic mitral regurgitation. Remember that although there is often a tendency to use transesophageal echocardiography in the ICU, that a VSD may be better seen with transthoracic echo. If you're using transesophageal echocardiography, do not neglect the transgastric view. And if you're shown a case like this, you should discuss the timing of closure and then whether it should be done percutaneously or with surgery. This is another example of a post-infarct apical VSD this time. So this is a 4-chamber view. This is the left ventricle, this is the right ventricle, and you see a high velocity jet at the apex of the left ventricle. Here in this 4-chamber view in subcostal through the subcostal window, you see that the interventricular septum is torn apart and that the defect, as it is usually the case, is quite serpiginous, and you see high velocity color flow through the defect. So to close this section on the imaging of ischemic heart disease, which of the following imaging findings indicate myocardial viability of a segment? So you may have guessed by now that the correct answer was A and D, so subendocardial late gadolinium enhancement of 25% of the segment and a biphasic response on dobutamine stress echo. So this concludes this section on ischemic heart disease, and I will see you back in the next lecture for about congenital heart disease.